afternoon, everybody.
Good afternoon.
Thanks for all having me at the Better Breathers meeting. I was excited to come and talk to you guys today about lung function testing. First, I just would like a show of hands. Can I see a show of hands how many people have had lung function testing done? Everybody? Even in the back, okay. All right, so have I, okay. In fact, I actually had mine done a week before giving this talk for the first time, just to make sure I knew what everyone was going through, okay. So my goal today is to have you guys become a little more familiar with the most common lung function tests that we do, and those are spirometry, diffusing capacity, and lung volumes. Those are, we don't always do all three, but those are the three most common that we do. And I want you to understand what those mean a little bit more when you look at the report with your lung doctor. We're going to talk about a little bit about what the most common types of impaired lung function are. There's people with obstructive lung disease, there's people with restrictive lung disease, and by the end of the talk I'm hoping you'll understand a little bit more about what that means. I want you to try to better understand how we score PFTs and how we interpret them, and then we'll sort of put it all together a little bit at the end. So don't worry, I know it seems like a lot, but we'll all be better breathers by the end of it, okay? So let's start off by talking about the most common PFTs. So first of all, what are pulmonary function tests? So you probably all recognize this picture. It's a picture of someone sitting in a box with a nose clip on, blowing into a machine, and we're measuring things. So essentially we measure how well your lungs work with these breathing tests. They don't tell you what specific kind of disease you have. They don't tell you what your favorite color is. They don't tell us anything about whether or not you're a nice person or not. They simply tell us how good your lungs work, okay? And why do we do them? Well, we want to measure multiple things. We can measure the flow of air, how fast you move air. We can measure how well your lungs exchange gas, and we'll talk about that in a second. And we can also just measure your total breathing capacity, okay, how much air your lungs can hold. Why do we care about that? Well, for one, it helps us to diagnose certain diseases. And again, the lung function tests by themselves aren't enough, but they are an extra piece of information that helps us decide what kind of lung disease a person might have. It also allows us to monitor your disease over time, so that we can tell if it's getting better, getting worse, if it's stable, etc. We can also use them to assess response to treatment. So if we check your lung function tests and we initiate some treatment and then repeat them, we can see if there's been any improvement with the treatment. And sometimes your physician will order lung function tests to be done before you have major surgery of any kind, because people with impaired lung function may have an increased risk of surgical complications, and so they may send you to have PFTs for that reason, okay? So the three major kinds that we do are spirometry, diffusing capacity, and lung volume. So let's talk about spirometry. Now, this is the one you've probably all done for sure, okay? This is where we measure how fast you can move air and how much air you can breathe out. And it involves basically sitting there in the pulmonary lab. You get a nose clip on so you don't lose any air out the nose, and you blow really, really hard into this little mouthpiece. You take a deep breath and you blow really, really hard, and they tell you to keep blowing out. There's usually a technician right over here who's coaching you along the way and saying, blow, blow, harder, 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 at least 6 seconds. And then we measure that on a little machine. And then we have you take a deep breath in. And what that machine does is it gives us some numbers, and it generates a little loop like this. And this is something we call a flow volume loop, and it's probably the most important thing that a pulmonologist looks at when it comes to evaluating these tests. So what is a flow volume loop? Okay, this is a flow volume loop, okay? It's basically a graph that is produced every time you blow out and then breathe in, okay? And on the horizontal portion of it is the volume. It's how much air you breathed out, okay? And on the vertical portion of it is airflow. It's how fast the air is blowing out, okay? So if everybody just takes a moment right now and just take a really deep breath in. Ready? Full deep breath, okay? And then blow out as hard as you can. Like that, okay? Now at the beginning, you feel that the air flows very, very fast, okay? And then as you go further with the breath, then the airflow slows down. But the fastest airflow is right at the beginning, right when you start exhaling, okay? And you can see that on the graph at the top there, and we call that the peak expiratory flow rate, or PEFR. That's the fastest rate of airflow you can achieve, okay? So that's one thing we look at with these. Another thing we do is the machine will measure how much air, the amount of air that you blow out in 1 second's duration during the first second. And we call that the FEV1, the forced expired volume in 1 second. That's the total amount of air that you're able to expulse in 1 second, in the first second, okay? Now, we still keep measuring after that 1 second. We measure all the air that you can blow out completely until it feels like you can't blow out anymore. And that volume of air we call the forced vital capacity, okay, or FVC. And that's the maximum amount of volume that you can blow out after a full deep breath. So when you take a full deep breath in and then blow it out all the way, if we measured all that inside of a balloon, the amount of that air would be your forced vital capacity, okay? And then the last thing we do is we take the ratio of the FEV1 and the FVC and we divide them by each other, and it gives us a ratio. And we'll talk about what that means a little later on, because that ratio, if it's reduced, tells us that you have obstructive lung disease. So that's a lot, okay? But basically, this is you, okay, smiley face, and when you take a deep breath, you exhale and then inhale, okay? Then that's how the curve is formed. You exhale, peak flow, and then inhale. So the exhale is on the top, and the inhaling is on the bottom, okay? I just really like this little animation, so I'm going to show it to you again. I really enjoyed that. That took a while to make, so I'm very proud of that. So you're going to see it one more time, actually. There it goes. I'm very proud of that. So aside from the flow volume loop, we also look at the volume over time, how much air you blow out over time on a volume time curve. And again, we can measure how much air you blow out in 1 second, which is your FEV1, okay, which is the most important number that we look at. And then we can measure all the air that you blow out after you fully exhale, the FVC, forced vital capacity. And then we divide them by each other and we get a ratio, okay? And we'll come back to that a little later on, okay? I forgot to tell you that there are going to be quizzes along the way, so just to make sure you guys are paying attention, can anyone tell me what the FEV1 is? What's the F stand for?
Forced.
Forced, okay. E? Well, it's the opposite of inhaling.
Exhale.
It's forced expiratory or exhalation, and V is for volume, okay? And what's the 1 for? 1 second, right, exactly. See, you knew it. It's the forced expiratory volume in 1 second. It's the amount of air that you expel in 1 second of forced exhalation, okay? What about FVC? And I'll give you a clue. The F still stands for forced.
Volume.
It is a volume, but what's the VC for?
That's what it is. F.
The total.
Volume.
Right, it's the total amount, and it stands for vital capacity, okay? But you're right, it's the total amount largest amount of air that you can blow out, okay? And then what about, what happens if your ratio is reduced? And I mentioned this.
You gotta divide them.
Yeah, you divide them by each other, and if that ratio is reduced, what does that tell the lung doctor that you have going on in your lungs?
Obstruction.
Obstruction, very, very good. That was a tricky one, because I only mentioned that once. Very good. Yes, if the ratio is reduced, it means your airflow is obstructed. And we will come back to that later on. So you guys get a thumbs up for that one. Good job, okay? There will be more quizzes, so pay attention. All right, so we talked about spirometry. Let's talk a little bit about diffusing capacity. So spirometry measures airflow. Well, diffusing capacity measures something else called gas exchange. Well, what is gas exchange? Well, you're doing it right now as you're sitting here breathing. You're breathing, and oxygen is going in, and carbon dioxide is coming out. You breathe in oxygen, you breathe out carbon dioxide. The exchange of those gases for one another is gas exchange. And your lung does this with these tiny little air sacs, okay? So when you breathe in, the air comes in, goes through the airways, and gets down to these tiny, tiny little microscopic air sacs. And these air sacs are right next to tiny, tiny little blood vessels. These air sacs are called alveoli, okay? And they are the site of gas exchange in the lung. They are the site where we take oxygen we breathe in and put it into your bloodstream to send out to your body to be used. And carbon dioxide, which is a waste product of your body, goes from your bloodstream into these little air sacs and is exhaled. And this happens with every breath you take for every day that you're alive. And this occurs by a process we call diffusion. Okay, so the oxygen and the carbon dioxide are going across these little membranes and diffusing either out of, the oxygen is diffusing into the capillaries and the CO2 is diffusing out of the capillaries, okay? And we can, this is, if you were to look at these, they would look kind of like a bunch of grapes. If you were to look at these little air sacs in your lungs, they look kind of like a bunch of grapes surrounded by these little capillaries, okay? And we can actually measure how well your lungs exchange gas by something called the diffusing capacity measurement. You'll see it on your pulmonary function test as something called a DLCO. Okay, the D is for diffusion, the L is for lung, and CO is for carbon monoxide. Okay, and basically what we do is we have you inhale a very small amount of carbon monoxide, not enough to harm you, but a very small amount. And by measuring how well that diffuses into your bloodstream, we can get a sense of how well your lungs exchange gas. Okay. And it gives us an estimate, essentially, of how well your lungs absorb oxygen, okay? Now, there are a number of diseases, and some of these you may recognize, but a number of diseases that can cause impaired diffusing capacities. Emphysema is one of them, okay? As well as pulmonary fibrosis, which is a kind of scarring in the lung. There's diseases of the pulmonary blood vessels, if you have a clot in your lung, or high blood pressures in the lungs, called pulmonary hypertension. We call that that's pulmonary hypertension. Then those things can decrease your lungs' ability to exchange gas. And then non-lung diseases like congestive heart failure or even low hemoglobin, anemia. Those things can all lower your lungs' ability to exchange gas. And why do we care about that? Well, the truth of the matter is if your diffusing capacity is very low, you might end up needing oxygen therapy. Okay, so a lot of folks who end up being on oxygen are probably on it because their lungs can't exchange gas very well, okay? This is a CAT scan of somebody with pulmonary fibrosis. The lungs are very, very scarred. You can see there's a lot of scarring throughout the lungs. And if you were to look at the little air sacs in this person's lung, you would actually see that there's a lot of scarring around them. And what should be a nice thin little air sac is actually very scarred and thickened. And so you can see that oxygen is having trouble making its way into that into the bloodstream because of that. Okay, so this person would very likely be on oxygen because their diffusing capacity is low. Okay, emphysema is another disease that can cause you to have low diffusing capacity because normally you should have these nice healthy little air sacs down there that can exchange oxygen and carbon dioxide very easily. But in emphysema, these become weakened and they collapse and they get filled with mucus and they don't absorb oxygen very well at all. And so people with emphysema can have low diffusing capacity, okay? And it's quiz time again, okay? What are those? What are these? Air sacs, yeah. Do you remember what they're called?
Something like.
Something lie? Okay, we got one syllable. That's good.
I don't remember what it was called. Something like.
Yeah, no, that's good. That's good. We got one syllable. I'll take that, okay? These are called alveoli, okay?
Alveoli.
These are the site of the gas exchange in the
Yeah,
lungs,
right.
okay? All right, can everyone say alveoli?
Alveoli.
Okay, good. Now, what's this?
Look like strawberry jam.
No, that's a bad picture.
It looks like raviolis.
It is. It absolutely is. Okay. Now, ravioli is a very delicious Italian dish, and I just wanted to, put these next to each other because they do kind of sound the same, and I know it can be kind of confusing. So these are alveoli, and this is ravioli, and I just want to make sure that these are always in the lungs. This should never be in your lungs. So I just want to make sure you all understand that. That was a terrible joke, okay? Thank you for laughing at it, okay? And with that, we will move on. We talked about spirometry, we talked about diffusing capacity, and the last thing we'll talk about regarding the types of lung function tests are lung volumes, okay? We don't do these on everybody, but basically what lung volumes do is they measure how much air you got in your lungs, okay? And there are two different ways to do this. They'll either have you inhale some helium, or they'll put you in this thing called the body box. How many people have sat inside the body box? Okay, so you've had that experience. So they put you in the box and they have you hold your cheeks like this, so we're not measuring the volume in your cheeks, okay? And you blow into the Yeah, exactly. That's why you hold your cheeks, because if you puff out your cheeks, then you're storing volume in there. We want to measure all the volume. Okay, so we have you hold your cheeks like that, so that we don't measure, so that we don't lose volume in your mouth. Okay, and I won't get into the specifics here. Just know that there's two different ways of measuring lung volumes, and your doctor may order one versus the other. Okay. So we don't just measure the total amount of air in your lungs. We actually divide up the volumes in your lungs into multiple different fractions. One of the most important we looked at is called tidal volume. Now, all of you are sitting here at rest right now, and you're all breathing. You're probably not thinking about it. You're just kind of breathing in and out, very small breaths. You're not breathing in as much as you can, and you're not blowing out as much as you can. You're just taking normal little breaths, and even if you were to fall asleep during this presentation, you would still continue to breathe like that, kind of like waves in an ocean. And that's why we call it the tidal volume. That's the normal resting breath. That's the amount of air that you move just with normal, regular breathing, okay? And if you notice, at the end of every breath, you inhale, and then you exhale, and then you come back to this little resting place. You always seem to know when to stop exhaling. You don't keep blowing out until you can't anymore. You just kind of hover in this little range, and you always come back to this little resting place. We call that the FRC, functional residual capacity. It's basically where your lung is most happy. It's not too inflated, it's not too deflated. It's just kind of at peace, if you will. Okay, and then your vital capacity, which we saw before, is your biggest breath. So this is what would happen. This is what we would measure if I tell you to inhale all the way and then blow it all out, and we measure that. Okay, and that's the vital capacity. And you breathe closer to vital capacity when you're exerting yourself or exercising. But even if you were to blow out all the air that you could, at the end of that, even if you felt like you couldn't empty any more air out of your lungs, there'd still be a little bit of air left inside your lungs, the little bit of residual air. And we call that the residual volume. That's leftover air that's still in your lungs that no matter how hard you try, you can't blow it out. So again, these are some of the more common volumes that we measure when we measure your lung volumes, okay? Now, lung doctors love graphs, so just to kind of show you what this would look like, okay? If we were to measure have you breathe into the spirometer, your tidal volume would look kind of like this. Normal little breaths, just up and down, not too big, not too small, okay? And at the end of every one of those breaths, you'd sort of come back to your FRC, your happy little resting place, your functional residual capacity, okay? If you take a really deep breath in, we call that your inspiratory reserve volume, and if you blow all your air out, the extra air that you blow out is your expiratory reserve volume. And if you add all those volumes together, you get the vital capacity, which is all the air that you're able to move, okay? But then you still notice at the bottom here, there's still some air left down here that you can't move. And we call that the residual volume. That's the air that's left in the lung at the end of a maximal exhalation that you can never actually get rid of, okay? And if we add up the residual volume to all the other volumes together, we get something called the total lung capacity. And this is the complete and total amount of air in the lungs, including the leftover air, everything. And we abbreviate that TLC. And this number is one of the things that you'll see, one of the most important things we look at when we are looking at your lung volumes, if those are measured, okay? So I'm not going to quiz you on all of these. I just want you to kind of understand that it's not just measuring the amount of air in your lungs, it's measuring certain different volumes and how they relate to each other, okay? One thing that that's important to understand is that you know, lung volumes can be abnormal in certain different diseases. For example, if a person has COPD, the airways are obstructed and they don't move air that well, okay? You might get in a situation where you have trouble emptying all the air out of your lungs, okay? And we call that air trapping. And on the left you can see is a normal lung. On the right is an obstructed lung. Now presumably this would be from different people, okay? You know, it's weird to have a normal lung on the right and obstructed on the left. But nevertheless, you can see that the obstructed lung is bigger because the air, they can't empty all the air out because the airways are tight from COPD. So they can't get all their breath out, okay? And what that leads to is the vital capacity goes down and the residual volume goes up. The air that you can move goes down and the air that you can't move goes up. And over time, what that causes is shortness of breath, because the air that you can't move is not helping you, and it's actually keeping your lungs super inflated and making it harder for you to move air. And we call that air trapping, and that's one of the symptoms that leads to shortness of breath in COPD. Okay? So those are lung function tests, and I'll just keep moving on here, and please keep in mind your questions for the end as best as you can. I'd like to now talk a little bit about certain patterns of lung function. We sort of alluded to obstructive lung disease as well as restrictive disease, but I'd like to talk about these a little bit more. But first, let's just consider what normal breathing is. Okay, in order to breathe, what do we need to do to breathe? What needs to happen to breathe?
Air in and air out.
Air in and air out, exactly. And how do we move air in and out? How do we do that? You breathe in and breathe out, exactly. And do you know how we take a breath? Do you know how we're able to do that? How do our bodies get air in there?
Your diaphragm?
Yes, absolutely, absolutely. So this is, on the left here is a person who's inhaling, and on the right, this person is exhaling. And in order to draw air in, the diaphragm has to go pull down, and the chest wall has to expand. And that pulls air in. It creates suction, and we pull air in. And then to get air out, the diaphragm and all the other respiratory muscles, they contract and they squeeze the air out, okay? And that's exactly how we breathe. That's the normal breathing. And you can see that the chest wall moves with breathing, okay? In obstructive lung disease, though, getting air in and out is a lot harder. And this is a person with chronic bronchitis, okay, which can be, it's basically a lot of mucus in the airways. And you can see this in COPD. And you can see on the left here is a person with a normal airway, with the airways nice and open, and it should be really easy to move air through there. But over here, the airway is thickened and constricted. There's a lot of mucus in there. Okay, you can look at the size of the hole on the right compared to the left. It's going to be like breathing through a straw here. It's going to be a lot harder to get air through there. And this is why this person is probably going to make a wheezing sound when they breathe, because it's air going through tiny little tubes instead of nice big open tubes, okay? Whereas restrictive lung disease, it's not a problem of airflow. It's a problem that your lungs don't expand as well as they should. It's a problem that your lungs, they simply can't expand. Either the lungs are stiff, or the chest wall is stiff, or there's something that's hampering the person taking a deep breath. But it's not an airway problem. And we go back to our person here with the scarring in the lungs. This person's lungs are very, very scarred and stiff, and they're not gonna expand as well. So this person will probably have restrictive, not obstructive lung disease, okay? And we can see this on a lung function test, okay? And we can actually, and when we remember the flow volume loop, we can actually see that obstructive and restrictive disease look a little bit different when we look at these lung function tests compared to a normal one, okay? So if we looked at them next to each other, if you look on the left, that's a person with obstructive disease. The thing that you see is that the curvature is very scooped out, okay? That shape is very characteristic, and we see that with obstructive lung disease, okay? Whereas in the restrictive lung disease, you usually don't see that kind of curvature, okay? What you do see on the obstructive is the ratio to FEV1 to FVC is reduced, whereas on the restrictive side, the problem is that the whole lung capacity is down. All the lung volumes are just small, okay? And the ratio is usually normal, okay? And if you look at them next to each other, next to a normal one, the obstructive person is going to have, you can see their peak flow is low, they're not moving air as fast, they have that curved, scooped out sort of shape to it, whereas the restrictive person, it's got the same shape as a normal curve, it's just smaller. But you don't see that scooped out, curvy looking things. The curve happens when you have obstructive disease, okay? And you can see, here's some more folks. This is a person with asthma, and this is a person with COPD. They're both different kinds of obstructive lung disease. And look, again, you can see the curviness here that you see. This person's probably got more severe lung disease because the curviness is a lot worse in this one, okay? But when you see that curviness, think obstruction, okay? Obstructive airways disease, okay? Diseases that can cause obstruction of airflow, asthma, COPD, okay? chronic bronchitis like that picture we showed, and then other airway diseases like bronchiectasis, which is basically the airways becoming very thick and dilated, okay? Whereas restrictive lung disease, there are more diseases that limit the expansion of the lung. So scarring in the lungs, fibrosis, people with sarcoidosis. Some folks who had occupational lung diseases, so we see sometimes folks who worked in factories and were exposed to harmful chemicals and get lung damage because of that, they can have restriction of their lung expansion. And if there's fluid in the lungs, if a person has congestive heart failure, that might make the lungs harder to expand and give them restrictive lung disease. But even stuff outside the chest, outside the lungs, can actually give you restrictive lung disease. If the chest wall muscles are just weak and you just can't generate a deep breath, that can restrict your lung expansion. How many people know what scoliosis is? It's curvature of the spine, basically, okay? And if the spine is curved and a person is hunched over like this all the time, it's really hard to take a deep breath. So even though the lungs are fine, if the lungs are squished from scoliosis, that can give them a restrictive picture on the lung function test. And even being severely obese is another thing that just can limit the expansion of the chest wall, even if a person has normal lungs. Another quiz. All right. So these are 3 flow volume loops, and they're numbered 1, 2, and 3. I want you to tell me which one is the restrictive one.
1,
2.
No, 2.
2.
Okay, we got this one right here, number 2. We got this one over here. It's a little smaller, number 3, and then we got this one over here to the left is number 1.
It's number 3. 2 is normal.
So 2 is normal, 3
3
is
is-
restrictive, okay? And what's number 1?
Obstructive.
Right, and how do you know that?
There's the curve.
Exactly, it's got the curviness to it, exactly. So well done, okay? So that's really all you have to look for. And a lot of times when we look at these tests, that's why a pulmonologist can look at these and in 2 seconds tell you if there's obstruction, because if they see that curviness there, then that's obstructive lung disease, okay? What's causing it, well, the pulmonary function test won't tell you that, okay? It's up to the doctor to try to figure that out with more tests and usually a history and an exam, okay? But absolutely, you got those absolutely right, and we'll give you 2 thumbs up.
That guy's a little creepy.
I know, I was supposed to make him smaller. He's really a little too excited. I think he's saying, I think he's happy because it's Friday, and well, I don't know. I really need to make him smaller. He's just, I think he'd frighten children, actually, that's to be sure. So. All right, so we talked about the common PFTs. We talked about the common patterns of lung impairment, obstruction and restriction. Let's talk a little bit more about how we interpret your lung function tests, okay? And this is important to know for when you go and have these done. My goal is that you can, talk to your doctor a little bit more, and when they look at the lung function tests and say they're fine, well, maybe after this talk you'll be able to talk a little more with them about it and understand how we determine that, okay? So the first thing we have to interpret is whether or not you gave us a good effort. I mean, you've all done these, okay, and they require a lot of effort. I mean, you have to take a big breath and you have to blow out and you have to blow out all the way, and it's kind of a miserable experience. It's not easy. You have to do it multiple times. You have to do it the same way each time. You can't be feeling too tired that day, if you're feeling sick that day, if you're unmotivated, if you can't keep a good seal on the mouth. There's 1,000,001 things that can cause problems. So the first thing we have to do is we have to assess effort and how well you cooperated and how well the test is reproducible from trial to trial. So if you do 3 trials in a row and they're all really different, it's probably not a very good test. I want to see you do the test and I want to see it come out kind of similar every time. That tells me that you gave a good effort, we got your best effort every time, and that this is probably a good test. Otherwise, the test is useless. But as long as you gave us a good effort and good cooperation, the next thing we do is we predict what your values should be based on a few things: your age, your gender, your height, and your race. And the reason for that is simple. A 6'5" African-American man is going to have who's 26 years old, is going to have a different lung capacity than a Caucasian 70-year-old female who is 4'9". Okay, so those 4 things: your age, as far as age goes, lung function decreases a little bit after you're normally after age 30 and decreases in a normal fashion, so we compare you to other people your own age. Gender, men tend to have slightly larger lung capacities, so we compare men to men and women to women. And height, it determines the size of the chest wall, just chest cavity. So we compare you to people your same height. That's why whenever you have these done, we always get a height on you before doing the lung function test. And race, because we've shown that there's been some differences between Caucasians, African Americans, etc. And then once we've predicted what your numbers should be, then we compare your actual numbers that you just produced. And we calculate what we call a percent predicted normal. So if my FEV1 is supposed to be, let's say my FEV1 is supposed to be 2 liters, and I only blow out 1 liter in 1 second, that's half of what I should be doing for someone my age, etc. So my percent predicted normal would be 50%. Okay. So if I blew out only if I only blew out a half liter, it would be 25% predicted. Okay. So that's how all of the values are reported. Is they show the actual value, but they also show the value as a percent predicted, based on your age, gender, height, and race. And then we interpret the findings. We decide based on how the curve looks and all that, whether it's obstructed or restrictive or mixed, both picture, or if it's normal. And then we grade the severity based on how bad the FEV1 is reduced. And that either turns into mild, moderate, severe, or very severe. Okay? Now, as I was saying before, there's 1,000,001 things that can mess up your PFTs, and this is only a few of them. Okay? If you're feeling tired that day, if you're coughing during the testing, if you're acutely ill, if you're having bronchitis, if you're just not giving us a good effort, if you're not cooperating, if you're letting air leak out around the mouthpiece, okay? If there's a language barrier, you know, if someone's there and only speaks Spanish and doesn't have an interpreter with them, it's going to be really hard to get them to do the maneuvers to get the testing done right. People with, you know, cognitive impairment or developmentally delayed, it's very challenging to get lung function tests done because they have trouble following the instructions. The equipment can fail. And this list, anyone who's administered lung function tests knows that this list is not exhaustive. Okay, there's a lot of other things that can mess it up. So we always have to kind of be mindful of that and be wary of that when we're interpreting the results. Okay? All right, so we're almost there. So now that we've learned all about PFTs, let's try putting it all together. We're going to do a couple of cases. So I'm going to make you guys the pulmonologist right now. We're going to go over 3 cases, and I want to see if you can make the diagnosis, okay? So this person is a 51-year-old person, white male, 6'1", used to smoke heavily, uses oxygen at home, okay? There's chest x-ray shows that his lungs are very big, okay? Very big. You can see they're super big and inflated, okay? So we get lung function testing on him. We see that his FEV1 is severely reduced. His forced vital capacity is moderately reduced. The ratio between the two of them is reduced. And his peak flow is also very reduced. Okay? Further testing shows that his diffusing capacity is somewhat reduced, but he's got normal total lung capacity. His residual volume, that leftover air in the lungs, is increased. Okay? And this is what his flow volume loop looks like. Does anyone want to take a guess at what, or tell me what you think this person has going on in their lungs?
COPD.
COPD, exactly. And what makes you say that?
The curve and the results of the testing.
Yeah, exactly. And anything specific in the results of the testing that make you say that this person's got obstructive lung disease?
You can't get it in and out.
Hmm?
You can't get it in and out.
You can, exactly. And
The
if you
exchange of gases is matter.
exactly, and this is probably from emphysema, okay, which is destruction of those little air sacs. And those little air sacs are called? Yes, alveoli.
I'm Italian, I remember ravioli.
I remember, yeah, exactly. So, not ravioli, right? Okay.
But wouldn't he have got emphysema ahead of getting COPD?
Well, you know what, though? I will answer that question at the end, but that is a very good question, okay? But yes, on this one, the big things that tip you off, aside from the curvature here, are the fact that the ratio between the FEV1 and FVC is reduced. Okay, whenever we see that and this kind of curvature, we know there's obstruction. And because the FEV1 is severely reduced, and that they have that curvature, we call it severe COPD. Now the other thing is that residual volume is increased, okay? Now what does that tell us?
It's not getting the air out.
They're not getting the air out, it's trapped. So this is severe COPD with air trapping, okay? And I'm sorry that didn't quite work, it's supposed to circle that, okay? But yeah, exactly, this person's got such bad airway obstruction that they can't get all the air out, okay? This person's probably very short of breath, possibly on oxygen, and probably gets very short of breath with exerting themselves, okay? So good job. All right. So our second patient comes into the office. Now this is another Caucasian male, 65-year-old. He's obese. He's about 5'7". Never smoked, but he worked with a lot of really dangerous chemicals at a factory for many, many years. He's retired now. His lungs look very scarred, okay? They're not big like the other person's, but they're just scarred on the chest x-ray. So we get lung function tests on this person. We find that the FEV1 is severely reduced. The forced vital capacity is also severely reduced. And when we take the ratio between them, it's normal. The peak flow, the amount of air, the fastest rate of airflow that we measure, is also normal. And if we look at the other values, we see that the diffusing capacity is severely reduced, and the total lung capacity is also reduced. And this is what this person's flow volume looks like. So what kind of defect in ventilation is going on with this person?
Pulmonary fibrosis.
Probably, and very, very likely. And as far as what that's causing in terms of obstruction or restrictive lung disease, what kind of deficit would this person be having?
It's restrictive and he's not able to
Right.
get enough air in and enough out.
Right, exactly. It's restrictive lung disease, and the things we can know is, you can see, I'm sorry this isn't coming through, but basically the things that we notice on this person is the FEV1 to FEC ratio is normal. Okay, the FEV1 is reduced, but it's reduced proportionately to the FVC. So when you take the ratio of them, the ratio is normal. So this person has a normal ratio, and you also see that they don't have quite the curvature, a little bit, but not nearly as prominent as the other person. You also see that the total lung capacity is reduced, whereas the person with obstructive lung disease is normal. Okay, so the TLC is reduced, and it makes it kind of squished. Okay, this is severe restrictive lung disease, probably from pulmonary fibrosis from occupational exposure to harmful chemicals.
Dangerous chemicals.
Yes, exactly. Okay. Now, case number 3, this is our last case, okay? So this is an African-American woman, she's 55, she's about the same height as our second patient. Former smoker, has lung fibrosis, scarring on her chest x-ray, and she's on oxygen at home. And we see also she's got emphysema as well on her chest x-ray when we look. When we do lung function testing on her, and we find that her FEV1 is moderately reduced, the FVC is mildly reduced, and the ratio is reduced. So the ratio is reduced. What does that tell us? Ratio is reduced. What does it tell us when we have a reduced ratio?
More obstructive.
More obstructive. This tells you of obstructive, right? But we also see that the diffusing capacity is severely reduced, which is probably why she's on oxygen. Okay? And the total lung capacity is also moderately reduced. And when our lung capacity is reduced, what does that tell us? Is that more obstruction or is that more restriction? When the lung volumes are all reduced? Restriction, exactly.
Restriction.
So, kind of a mixed picture. Well, in fact, you can have the curviness, okay, which you see there, but you can also have the fact that this person's total lung capacity is reduced, because you can see that we sort of graphed what it should be right here. So this person actually has both. This person has combined obstructive disease and restrictive disease. This person's chest, the lung expansion is limited probably by the scarring, and the person is not moving air well, probably from the smoking-related lung disease. So there's a mixed picture with this one. So the take-home point is that it's not always just one or the other. You can have elements of both obstruction and restriction. So good job. You guys did a fantastic job on all 3 of those. So you got 3. I hope these are a little less scary. Maybe the second one was a little bit worse. But anyway, Good job. So what did we learn today? I hope we learned something, but my hope is that we all know that PFTs, or pulmonary function tests, they help us understand how well your lungs work, okay? There are multiple different things that we can measure. Spirometry measures how fast you move air and the amount of air that you can move, air flow, air vital capacity, etc. The diffusing capacity measures how well your lungs exchange gas, how well they absorb oxygen from the air and bring it into your bloodstream. And then lung volumes, which we don't measure on everybody, but we do sometimes measure your total lung capacity and other lung volumes, okay? And by doing this, we're able to see two major kinds of lung dysfunction. Okay, obstructive airways disease is where the airflow is reduced, where we can't move because the airways are tight. Whereas restrictive lung disease, the problem is the lungs aren't expanding as well. So it does also make your airflow go down, but it's not because of tight airways. It's because of restricted lungs that don't expand as well as they should. And there's a variety of diseases that can cause both of those. And the last thing I want to mention is that testing is always effort dependent. You always have to make sure you are giving your best effort with these, and if you're not giving a good effort, then, or if you're not feeling well that day, you need to let your doctor know so that they can take that into account whenever they're interpreting your test results. And with that, I will conclude, and looks like we have plenty of time for some questions.